present this seminar. This is one of our patient safety research collaboration safety net seminars, so it's open to a very wide audience, and it's fantastic to see so many of you joining us today. And I'm Rebecca Lawton, and I'm director of the Yorkshire and Humber patient safety research collaboration funded by the NIHR. So Tracey is going to talk to us about something that's of really of great importance at the moment to many of us, and I know many people in the service are in the depths of implementing the patient safety incident response framework as we speak. So I've no doubt that this talk, which is about where we are and where we're going, will be of huge interest to so many people at the moment, Tracey. So just a huge thank you to you for coming along and talking to us today. So Tracey is she has a very interesting background. She's a chartered human factors specialist, a chartered psychologist, and has a PhD in applied psychology from Cardiff University, and she specialised in human perception and performance. So a huge range of fantastic skills that are extremely relevant to the field of patient safety. And Tracey seems to be somebody with an eagerness for learning, because she's also studying at the moment for an MSc in Translational Health Sciences at the University of Oxford. So continuing to grow her expertise in this area. At the moment, Tracey is seconded into the role of Deputy Director of Patient Safety Digital at NHS England, where she's actually leading work to improve the safety of digital technologies and to identify and promote the use of digital technologies to improve patient safety and address patient safety challenges. But Tracey was, prior to this, the head of the patient safety incident response policy, and so has been responsible for the day-to-day strategic leadership around this project, and so probably is the best placed person in the world to explain a patient safety incident response framework to us, and how it's being implemented and impacted by research in this area. So without further ado, Tracey, I'm going to hand over to you, and we look forward to hearing from you over the next 40 minutes or so. If anybody has any questions that they are eager to ask and don't want to forget, please just pop them in the chat as Tracey's speaking. We don't normally ask people to interrupt, but if you can pop them in the chat, I will pick that up later. And the only other point of housekeeping, if people could please stay on mute. It's lovely to see your faces, but if you could stay on mute while Tracey's talking, that would be fantastic. Thanks very much, and over to you, Tracey.
Great. Oh, yeah, thanks very much, Rebecca. And yeah, really happy to be here to talk about PSIRF, even though I'm kind of on secondment at the moment. I don't think you ever really get to leave it behind. So this is, like you said, it's a huge piece of work that's going on across the system right now, and there's been a huge team behind it. And I'm just kind of noted a few of them on this slide. So my colleague Lauren Mosley, Rachel Poole, Donna Forsyth, who was involved in the development of the framework before 2020, and of course Matt Fogarty, our early adopters. And I think at the moment it's it's really affecting all of the work we do in the National Patient Safety Team. So it is such a huge piece of work, both within the patient safety team but going on out there in the system. So lots of people involved in the development of this framework. So just a brief overview of the things I'm going to talk about today. So always good to start with what is PSIRF. So the PSIRF, Patient Safety Incident Response Framework. So I have a slide just to kind of give a brief overview of that, a little bit around how we developed it, what work has gone on since we published the framework in August 2022, and then what next, what comes after, what's life after PSIRF, and what are we looking towards in the future, and how we further develop the framework. So what is PSIRF? So I guess in a nutshell, the Patient Safety Incident Response Framework replaces what we previously had in place, the Serious Incident Framework, and it moves us from quite a prescriptive framework which specified that the organizations must use root cause analysis, so specified the methodology and specified when this method needed to be applied. So under the serious incident framework, it was for those incidents that met a certain threshold of seriousness must be responded to using a root cause analysis for learning and improvement. Under PSIRF, we've moved to a much more principles-based approach. So organizations are still responding to safety events for the purpose of learning and improvement, but in doing so, the PSIRF is asking organizations to respond using 4 principles in the way they go about doing it. So ensuring that the response is compassionate, that we're meaningfully and compassionately engaging with those who are affected by the safety event. We want responses to be proportionate so that they're focused on areas where there's the greatest potential for learning and improvement. We want responses to be systems-based, so focused, and this isn't necessarily something new, but focusing on understanding how the safety event happened and not who to blame for the safety event. And then also we want our responses to safety events to be supported. So those who are in oversight roles in relation to learning from safety events, we want to focus on enabling improvement and to move away from some of the bureaucratic approaches that we may have had in the past, where we're, for example, counting number of incidents and so on. So we want to move more towards an approach that enables improvement. So they're the main 4 principles that we're asking organizations to apply, and I'm sure I'll talk a little bit more about this in a few slides' time. So that's PSIRF in a nutshell. But how did we develop it? And I think key to this is our early adopter program. So just to give you a little bit of a timeline around the development of PSIRF. So like I mentioned, starting with the serious incident framework back in 2015, the goals of this framework, I think we could very much agree with. They're very similar to PSIRF, although the way the kind of requirements of the framework and the way this was enacted and put into practice didn't really enable us to achieve those goals. And there were a number of national reports that called for change. And in response to this, in 2018, the National Patient Safety Team did a huge engagement piece to try and understand what we need to do, what needs to change to enable us to reach those goals of learning and improvement. And this then led on to the development of PSIRF, our early adopter framework, early adopter program. Our early adopters tested an introductory version of the framework that was published in March 2020, which was independently evaluated and led to the publication of a revised version of PSIRF in August 2022, with the expectation that organizations transition to PSIRF by autumn 23. And then as of April this year, it became part of the NHS standard contract. So just a very brief overview of the history of PSIRF so far. Just to give a little bit more detail, just to kind of, I've gone back and looked at all the work that went into the development of the framework, and this is before my time on the team. So looking back to that engagement work that happened in 2018, the national team did an online survey. We had over 400 responses. We did national workshops in person. I think I attended one of these as an attendee to give my thoughts on the serious incident framework and PSIRF. We did live Twitter chats when they were a thing, and then also kind of discussions of patients, families, NHS staff, regulators, and others. And I think this then led on to stage 2, where the conclusion was that tweaking the serious incident framework wouldn't be sufficient. We really needed to rethink and kind of restructure the way we go about learning and improving following safety events within the NHS. And because this was such a significant shift, there was the requirement to pilot it and really test it and understand how the framework, the new introductory framework, would be enacted in practice. And so this then led us on to working with our wonderful early adopters that I've learned so much from. And we've worked with them from October 2019 until around May 2022, where we had a farewell webinar with our early adopters. We still continue to work with them, so I think we meet quarterly. Still with them, they're still that we had a discussion at what point do they no longer become early adopters and they just become organizations working under PSIRF, because there is this sense that we're always learning and improving over time. And I think that's one of the main positives that come with PSIRF as a framework, is that opportunity to always be continuing to learn and improve and adapt the way we go about our responses to safety events. At our farewell webinar, we also had some PSIRF cake. One does say PSIRF with some M&Ms, I think. I don't know if that's clear, and we also had a SEEPS cake. So this is one of the, I guess, socio-technical frameworks that are associated with PSIRF. So the Systems Engineering Initiative for Patient Safety, which is, I guess, almost kind of become embedded in the work, kind of how we go about learning and improvement. And this was a cake that has the SEEPS framework on it. So just to kind of talk a little bit then around the independent evaluation, I thought it could be quite interesting just to think about some of the questions. And this was independently commissioned. It was led by an organization called CRISQI, and the report for this is available on our Future NHS site. We really wanted to understand what worked, what didn't, what were the challenges and benefits of PSIRF, were there any unintended consequences? The methods of this were primarily qualitative methods, so kind of through surveys, interviews, although we did collect some quantitative data. So we were looking at the number, kind of what learning response methods organizations used, how many investigations were they conducting, and how did this compare to the level of response activity prior to the introduction of PSIRF. And we also developed a theory of change with the researchers to really understand the kind of thinking behind PSIRF and what we were hoping to achieve with the framework. So then we went on to revise the framework, and this was a significant piece of work. There were many recommendations that came from the evaluation. So in a nutshell, ultimately the evaluation said that PSIRF was the right thing to do, but it required a significant amount of support, and there were some things that we needed to adapt. So we started to redevelop the framework. We had a weekly update group who kind of document revision. We were able to work with some colleagues out in the system, so we were able to commission some work to help support the development of our oversight guide and the development of our learning response tools. And the learning response tools were developed in a kind of iterative way. So we tested them with some organizations who were willing to work with us to put some of the learning response tools to test, and we were able to adapt them before we published them alongside all the other PSIRF documentation. We were also able to collaborate with the Learn Together research program and colleagues from, at the time, the Healthcare Safety Investigation branch to develop our engaging and involvement guidance, which is a key piece of guidance that sits alongside the PSIRF framework and specifies how we should be going about engaging with those affected by safety events. And there was a huge amount of research that went into that piece of work, and it was still ongoing. And one of the commitments we made when we published that document is that we would update that document, that guidance, based on the findings of the research once that research was completed. And so that's some of the work that we're doing at the moment, is looking at how we can improve that engaging and involvement guidance based on the final findings from that Learn Together research program. We did a whole bunch of comms and regional roundtables to test some of the ideas and how we go about introducing PSIRF as a framework and so on. And this all led to the publication of the framework later, I guess, than what we'd hoped for, but in August 2022. And we had a launch event for it on the 5th of September 22, where we had over 4,000 people sign up to attend the webinar, and I think about 2,000 people attended that launch event, to just show the amount of interest in PSIRF as a framework. So what's changed then since publication? So taking it back to those 4 principles that I mentioned at the beginning. So PSIRF is more principles-based, where we're asking learning responses are compassionate, proportionate, systems-based and supported, what were some of the actual changes that we made underneath these 4 principles? So for the compassionate principle, like I said, we were able to work with the Learn Together research program to publish new guidance, which included training and competency standards. For the proportionate principle, we were able to, we were requiring organizations now to develop a patient safety incident response plan. We removed a mandated threshold for serious incidents, and that anything that met this threshold must be investigated, and removed the requirement for a specific methodology in how we learn and improve. So that being root cause analysis. And we're actually trying to move away from root cause analysis as a method for learning and improvement, recognizing, I guess, the complexity of the systems within which we work within healthcare. So under the systems-based principle, we developed a learning response toolkit, which replaces the single method that was prescribed previously. We've asked organizations to start to consider embedding, how they embed safety within a wider system of improvement. So how do patient safety colleagues work with quality improvement colleagues? And I know some organizations are really trying to give this a go, and it's not always easy. I think we tend to speak different languages, so it has been a bit of a challenge, but I think it's a really important part of PSIRF to start to work together across our organizations to think more broadly about how we learn and improve and what skills we need to enable us to do that. And then we've also introduced some training and competency standards for those who are leading learning responses. And then finally, under the supported principle, we changed the roles and responsibilities of organization boards and of commissioners. We've removed what was previously in place was the 60-day time frame to complete a learning response, recognizing that a one size does not fit all, and trying to reach the 60-day time frame could often impact on the ability to engage with those affected. So it's not that we're getting rid of timeframes altogether, but that these should be set in conjunction with those affected to enable them an opportunity to contribute to the learning response. We introduced some peer review and also some training and competency standards. So around the time of the introduction of PSIRF, we were really keen. I know when patient safety folks out there could really see the benefits that PSIRF would bring, and were quite keen to get going, and recognizing that once organizations had developed a patient safety incident response plan that was agreed with their stakeholders and their commissioners, that they could transition. We really wanted to almost try and slow organizations down, so we didn't end up with the serious incident framework, but just calling it PSIRF. So our SI panels, just referring to them as PSIRF panels. So we didn't want to have a bag of muesli and turn it into a bag of muesli and still be the same contents within the bag. I think this is one of my favorite bits of the animation. We originally started with Crispies and Crunchies, but felt like we needed something a little bit healthier, so we went with muesli. So it was really important that we tried to slow organizations down to really think about that foundational piece, what needs to be in place before we then start to develop our plans and try to implement them. And we developed a preparation guide, but like everything else with PSIRF, since it's been introduced, there have been wonderful, like amazing creative work going on in the system that's really brought PSIRF to life. So this is a representation of our many pages of preparation guide in one slide about what we wanted organizations to consider as they went through their preparation to transition to PSIRF. Just a quick review of kind of a hashtag PSIRF on Twitter. There's been a huge amount of work within organizations across the system in how they're trying to raise awareness of PSIRF and teach their staff around what PSIRF means and what changes it brings, from kind of trolley dashes to t-shirts, and organizations have developed their own logos. And so I thought I just wanted to kind of share, and I think pens in patient safety orange. So there's been a huge amount of work going on in the system, and now kind of the knowledge around PSIRF and that expertise really sits within organizations. And one of the things I've really noticed is that although we have a forum for PSIRF online on our Future NHS website, the responses to questions actually come from colleagues within the system now. They're not necessarily led by us in the national team, just to show how engaged people are and in working with PSIRF and trying to move it forward. So I really wanted to share some of this work that's going on. It's super creative. Of course, in the national team, we've been doing a whole bunch of stuff as well. So we've been trying to get the word out around PSIRF and to attend a number of different events and speaking to different audiences, from the likes of HSJ Patient Safety Congress to colleagues within, say, the Chartered Institute of Ergonomics and Human Factors, to clinicians, to broader conferences and so on. We've really tried to kind of reach a huge variety of audiences to talk about PSIRF, to understand what the concerns are, to listen to questions, answer them, and so on, and then adapt how the information that we're putting out nationally in relation to PSIRF. So we produce a number of podcasts. I love a podcast. We have our forum, like I mentioned, but the majority of our work has actually been around working with national stakeholders, because like as much hard work that goes on within organizations, if we're thinking about how thinking about taking a systems approach to how we respond to safety events, there's always that kind of wider external context that impacts how we can learn and improve within our own organization. So a lot of our work has been around trying to influence that wider external context, working with colleagues in the CQC, with coroners, and so on, professional regulators and so on, to try and create that wider context for organizations to enable PSIRF to succeed. Of course, we also have the response study, which is led by Jane O'Hara and colleagues, and Rebecca, I think you're part of that as well. And this is a really important piece of work that's looking at the implementation of PSIRF in practice. So there's a website, and the link is on the slide, and I'm sure you can Google it and get there, find it quite easily. So this is a really key piece of work that's been following organizations from pre-transition to PSIRF through their transition to PSIRF, and really understanding kind of how that's happened in practice and what some of the challenges are. And we've been kind of following that nationally, and it's going to really help to inform some of the work that we do in the future when we think about the what next. So this is just a sample, really, of the patient safety incident response plans that have been produced across the system. And there's a real variety. I did a small piece of work where I reviewed around 20 patient safety incident response plans, and working with our PSIRF patient safety partner, who looked at all of the patient safety incident response plans that he could find online. At one point, there was over 120 of them. I'm sure there's many more that he's reviewed now. And we presented some of this work at the IHI BMJ conference earlier this year, that I just wanted to share with you as part of this talk. So interestingly, the question I guess that many people will be asking is, we have all these organizations across the system that are creating their own patient safety incident response plans. Are there any similarities across the plans? What are the differences? And just looking at the 20 that I'd reviewed, these were some of the most popular, I guess, priorities for organizations when it comes to learning response activities. So this is looking at a cross-section of acute providers, mental health providers, but also ambulance and community as well. And so, as you can see, medication and pressure ulcers are key, but also self-harm, deterioration. I tried to look at it across both acute and mental health providers. And you can see that there are quite a few similarities between the different providers. So medication comes out quite a lot, self-harm, falls, pressure ulcers, delays, discharge, and so on. So there are quite a lot of similarities in the priorities that organizations are setting for themselves in terms of what they're going to be responding to for the purposes of learning and improvement. And so what were some of the conclusions that we had based on that kind of brief piece of work? Well, it was really clear that publishing a patient safety incident response plan is just the beginning of PSIRF. So although we had that kind of, that preparation guidance, how do we prepare to transition? What are some of those foundational pieces that we need in place? Getting to that point where organizations are developing their incident response plans collaboratively, getting those agreed with commissioners, and then transitioning. Although there's a huge amount of work that goes into it, that is just the beginning of, I guess, the PSIRF opportunity, the journey and how we learn and improve from safety events. And some of our ICB colleagues have kind of described their work in PSIRF and supporting organizations. It's not that they're implementing a framework, but that they're leading a culture change. And some of the reflections that we had when we were looking back at these patient safety incident response plans is that the plan itself isn't, I guess, a mandated list of things that organizations must respond to or not respond to. A plan is a plan as best as it can be based on, an understanding of that organization's data. But it does support that opportunity to move away from what previously was a reactive approach of how serious is this event? Okay, then we must do an RCA, to making more nuanced and more informed decisions around how we respond based on an understanding of what our concerns are within our organizations, but also an understanding of what improvement work we have ongoing within our organization, and how the insight that we gather from our learning responses can be used to inform that ongoing improvement work. The key thing about the patient safety incident response plans is that they are like a massively rich source of data about safety concerns across trusts in England. And I'm already aware, it's a really interesting piece for us to look at nationally, although it was just kind of a small snapshot at the moment. There are already a lot of interest in these patient safety incident response plans and what they can tell us about patient safety across an organization's perceptions and approaches to patient safety across England, and the requirement is that organizations publish these plans on their external facing website. And where we find there's overlap in safety concerns, this offers itself as an opportunity for wider collaboration across a system. So commissioners are agreeing these patient safety incident response plans with providers. And although it's not a requirement at the moment, there is the opportunity there for commissioners and those in ICSs to create a broader plan, that builds on what the incident response plans are telling them across their system, and try to coordinate some collaborative working across organizations that are looking at similar priorities. So there's a real opportunity there for shared learning and collaboration based on what organizations are understanding as their priorities within their organization. Some of the opportunities we saw then for the development of patient safety incident response plans is that there are real opportunities to improve clarity for patients. So recognizing that these plans are published on organizations' external facing websites. So for patients who may have been affected by a safety event, it may be their first port of call potentially. So there is definitely room to improve how we write our incident response plans to make sure that they are clear for patients to understand what to expect and what an organization's priorities are. There are definitely opportunities to be more proactive. And at the moment, the patient safety incident response plan is based on how we respond to safety events. So in that sense, it's defining how we will respond retrospectively. But there are real opportunities once organizations have looked at their data, so looked at both the kind of the harder data around their safety event recording data and their previous investigations, but also some of that softer data around what is keeping people up at night, and understanding the improvement landscape within that organization. All of that knowledge can be used not necessarily to then say and once an incident happens, this is how we will respond. But if there's an opportunity there to be more proactive, so we know we have a concern around this particular issue, let's use that information to do more of a proactive approach. So we may do some observations, some cognitive walkthroughs, and some of the tools in that learning response toolkit in a more proactive way, rather than just defining how we will respond in hindsight. And then there's a real opportunity as well to focus more on inequalities. So under the serious incident framework, where we were set more on kind of a threshold and responding to incidents that met a certain threshold, under PSIRF, we have the opportunity to consider patient safety inequalities as a priority within our patient safety incident response plan. Whereas previously, these may not have met, some incidents may not have met that threshold, so didn't have an RCA, for example. There are opportunities now to look more so at other types of events that may not have been of significant harm, for example, and include inequalities as a priority within patient safety incident response plans. And I could see that organizations were starting to consider this and kind of looking at what data they had, what data they didn't have, and how they need to improve that data collection in the future to be able to further consider inequalities in our patient safety incident response plans. And I guess linked to the potential for being more proactive, is there potential there to focus more on improvement priorities? So using that kind of understanding of our data and improvement work and setting improvement priorities that are more proactive rather than just response priorities, which we're kind of setting at the moment. So there's a lot of work to be done there, I think, in looking at the design of the patient safety incident response plan and looking at how that might evolve in the future. And I think some of our early adopters are starting to consider some of these ideas as well. So next steps. So I've started to touch on this a little bit already. So PSIRF and beyond. So there's definitely work to do around the learning response toolkit. So SEEPS, the Systems Engineering Initiative for Patient Safety, is one framework that is a thread throughout that learning response toolkit. But it is just one framework. It's one lens that we can use to look at a system, and other frameworks and lenses exist that will help us to look at the context in a different way. So how do we start to build on the toolkit that we've already developed and start to consider how these different lenses and frameworks can help us in how we go about learning and improving? So that's a piece of work that I think will be worthwhile to pick up in the future. I think SEEPS is very important. We've selected that for a number of reasons. And it was important to have that thread in the initial iteration of the learning response toolkit, to have that kind of single narrative in a way. But there are opportunities to expand that and to develop on it. And organizations are already starting to do this for themselves. One of the latest things that we've produced is a draft after action review report template. So and we have a webinar coming up specifically looking at the report template and how it can be used in practice. I think there's a real potential that after action review just becomes the next SI or kind of RCA. And so one of the things we tried to do in the report template was try to remove some of the bureaucracy that we started to see creep into some of the templates that were being shared around, and to try and reflect back on what is the purpose of this method and how it helps us to learn and improve, and in what circumstances is this method appropriate, and in what circumstances may other methods be appropriate, and how can we build on, I guess, the insight that we gather from this as a method, and maybe use complementary methods such as observations and so on. So I think there's lots of work to be done around how the methods for learning responses, so that so it doesn't come back to everything that previously used to be an RCA is now an after action review, because that isn't the intention of that as a method or of the kind of learning response toolkit. We've been offering nationally a number of different webinars. So we started with our transition webinars, which we ran from 22 to 23, and then we're currently running a series of embedding webinars. I think these have been really important to help us understand the questions and understand how organizations are going about embedding PSIRF, and I think we will continue these in the future. We may change the name to something around improvements, innovation, and sustainability, or maybe something a little catchier, but we're hoping to continue these in the future. Training in PSIRF, I think, is really important, and it's definitely been recognized that PSIRF as a flexible framework still has very prescriptive training requirements. How can we make these training requirements more sustainable over time once we've had that initial push? How do these training requirements link to other patient safety offerings, for example, the patient safety syllabus and so on? So that's a piece of work that's being picked up. Primary care is definitely an area where we can do lots of work to try and improve, learn how we go about learning and improvements in that sector. We've been doing some work already. This was one of the recommendations that came out of the independent evaluation. We've been doing some work already in this area, but the work that we're moving forward with at the moment is a focus specifically on general practice, and we've been able to commission one of our patient safety collaboratives in South London to lead a pilot around PSIRF in primary care, and I think I have a slide on that coming up. And also safety management systems is a huge buzzword across the NHS at the moment. I think my approach is to more kind of try to understand it a little bit more cautiously. What does this mean for us in healthcare? And I have a slide on that, so I'll come to that in a moment. So we have already been doing some work around PSIRF in general practice, and we do have some resources available and some more to come on the NHSE website, more of just a brief questions and answer about how PSIRF principles may be applied in general practice. So this is a video that's available on YouTube with an interview with a GP who's also the kind of medical director of a primary care network. So that video is available online, which talks about some of his reflections on trying to introduce some of the PSIRF principles there. And we've also done a podcast. I do love a podcast with the governance and risk lead from that PCN as well. And that's available online. And these will all come together in a page that we'll have on our NHS England website once that gets published. So this is the work that we've been doing. So the Health Innovation Network South London are leading this piece of work around supporting the pilot of PSIRF in general practice. They have already hosted their own webinar, but if there are people on the call who are interested in potentially being involved in this pilot, if you're working in general practice, whether or not that's in a primary care network, a GP federation, or another area of general practice, and you're interested, then please do get in touch with Amy, whose email address is on the website, and that's by the 28th of June, so coming up quite quickly, but I just wanted to plug that while I had the opportunity. The Exploring Safety Management Systems is quite an interesting piece of work that I think relates to PSIRF and the direction we're moving in the NHS. So many of you may already be aware of the Health Services Safety Investigations Body. They made a recommendation to NHS England back in October last year around exploring the SMSs and the principles and the application within healthcare. And there was also another recommendation made more recently around the exploration of SMSs within healthcare through the Infected Bloods Inquiry. So what is an SMS? I think that part of the issue is the name, and oftentimes a safety management system is interpreted to be kind of a software system or something that's akin to the Learn from Patient Safety event service that we have in the NHS. But just to kind of give an idea of broadly how it's defined across different industries, more so as a systematic approach to managing safety. So these are some of the kind of definitions from aviation and nuclear, and we haven't provided a definition of what an SMS is in healthcare. And I guess the question is, do we need a definition around what an SMS is? And that's some of the things that we are exploring. I think ultimately how an SMS is enacted across different industries varies, but ultimately there are kind of 4 broad principles or pillars that underpin SMSs across different industries. And I think what is key in any work that we do is not that we just lift and shift something from a different industry, but that anything that we can learn, we are able to take and translate and make it relevant to the context within which we're introducing it. So it would be in a healthcare context. And healthcare is very, very broad context. So that's some of the work that we're currently exploring. So we have a safety management system coordination group, which is a forum to explore ideas, increase our understanding of SMS principles, and where appropriate to support progress in adopting SMS principles. I think there's a potential argument to be made that many of the principles are already adopted, but it's how do they work together in a systematic way. So we have this SMS coordination group. It meets on a quarterly basis. It has colleagues from across the system, but also from other safety critical industries, the likes of aviation and rail. And we come together to really understand what work is going on across the system with regards to SMSs in healthcare, so that we're not duplicating each other's efforts, and it brings together an opportunity to kind of share that work and to build on it, but then also to consider how this gets applied within a healthcare context. So HSSIB have already produced a report on this as an introduction to safety management systems, and are going to produce 2 further reports on this around accountability, and also one focusing on involving NHS staff and patients. We were able to commission some research through the Department of Health and NIHR with some questions around understanding the key attributes of successful SMSs in the NHS, the links between an SMS and a QMS, and the next steps for safety management in the NHS. And this research is completed now. It's going through peer review, so I hope to be able to share that quite widely afterwards. And what they've done as part of this work is to not necessarily look to other safety critical industries, but look at what work is ongoing already within healthcare around SMSs around the world. And they looked specifically at New Zealand, Canada, Ireland, and a couple of others that I can't remember off the top of my head. But ultimately, I guess they found that SMS principles can be found across healthcare and across different, parts of the world. But the place where SMS principles are being applied more directly has been in the Dutch healthcare service. And so there's lots of potential learning there on how we can learn from their experience, because although there was some positive effects of applying these principles, the effects were varied, as you can imagine, across the system. And so I'll be really happy to share that work more broadly afterwards, and that's going to contribute to the work we do in that coordination group. And then, of course, we have some work going on through the research group up in Yorkshire, looking at safer systems, where they're also exploring safety management in other safety critical industries, and are bringing in some of the members of our coordination group to inform that work. So lots of work going on in this area, all kind of flowing into this coordination group. And all, I think, will help us to build on the work we're already doing on PSIRF, and potentially support us to be more proactive in how we identify risks and so on. So all of that is kind of to watch this space, I guess, in the future. And then I had a slide, and then I think I mentioned at the beginning, PSIRF, that one of the real beauties, I think, of it as a framework is that it's not something that's kind of stagnant in the same way as the serious incident framework was, that anything that met a threshold required a certain response. It offers that opportunity to constantly build and improve on how we go about learning and improvements. And as organizations are doing that, we're also learning nationally. And this was kind of picture where I went back and looked at some of the wireframes we had from the video that we produced to introduce PSIRF. And I think we've started to add some color around the edges to this, but I think we've still got a long way to go. And that is it from me. So I'm happy to take any questions, Rebecca.
Thank you so much, Tracey, for a really broad and fascinating talk about the development, the implementation, the research alongside, and what next. That was really very interesting, and we already have a good number of questions in the chat, and some really interesting ones as well. So I think I'll just go through them in turn, if that's okay with you. And the first one, Jenny, would you like to just state your question to Tracey?
Thanks, Tracey. That was really brilliant. Really enjoyed that. So I'm going to read my question because I've almost forgotten what it was. To what extent does the development and evaluation of PSIRF reflect how you would usually go about developing or changing policy?
Yeah, I think that's a really good question. And I think the whole early adopter program came about because it was such a significant shift. Because if you think back to how we introduced the serious incident framework, it was very different. It was kind of given to the system, and then organizations picked it up and ran with it. So I think that because it was such a significant shift, it led to the requirement for the early adopter program. And reflecting back on that, I think that was the best decision that was ever made in that kind of work that we've then done ongoing. And so it isn't reflective of the way we've done things in the past, but I think it's a great case study of how to continue to do things in the future, particularly with that evaluation work through the response study. And we're starting to build that into some of the other work that we're doing in the National Patient Safety Team as well. So the evaluation of the patient safety specialist role, for example, and similar work around patient safety partners. So I see that becoming an even, a bigger role for that as we move forward.
Thank you, Tracey, and great question, Jenny. So Justin has asked the question, is the PSIRF theory of change publicly available?
Yeah. So the theory of change that we developed with the CRISP-QI when they did the evaluation, it's in the evaluation report. So the evaluation report is available on Future NHS. I can share the links to that afterwards, or I can pop it in the slides before the slides get shared. And so there is a theory of change within that. And I think the response study have also been developing a theory of change. So once that's published, that will also be available as well.
Brilliant. Justin, is that okay for you, or is there anything else you wanted to add?
I did ask another question later on, but perhaps go through the other people's questions first, to be fair, and then come back to me this time.
Thank you. Hilary, who is one of the lay leaders with our team. Hilary, do you want to ask your really insightful question?
Yeah, I mean, I asked this question and really got the answer to it. It's how important is it for patients and relatives to have confidence in this new framework? But more importantly, how do we get that across to them? Because these principles really show that it's not about covering up, somebody's mistakes. It's a really important learning way. So it's how do we give the patients and relatives the confidence in this?
Yeah, absolutely. Great question. And I think so through having involved patient safety partners in the work that we've been doing, when we both looked at those patient safety incident response plans, we both looked at it through a different lens. And so it was quite clear when Mark, our patient safety partner, looked through them, he was picking out all those elements around how patients had been involved in the development, how the plan would be understood by a patient when it's published on an organization's website. So I definitely think there's work to be done there around how plans are written and shared and made accessible on organizations' websites. But I think there's also more work to do more broadly about how we communicate patient safety initiatives outside of organizations, if that makes sense, more broadly, because I guess you may not necessarily be aware of PSIRF unless you've been affected by a safety event. So I think there is something for us to learn and to improve on how we communicate these patient safety efforts more broadly. And I know that is something that we've literally been having discussions about just this morning in the National Patient Safety Team, but I agree there's more work we can do there.
Thanks, Tracey. We'll come to Mike next, who's asked a couple of questions. So, Mike, I don't know if you want to cover off both your questions, and then we'll see if we've hopefully got time for Ruth and Claire, and back to Justin.
Okay, thanks, Rebecca, and thanks, Tracey. Great presentation. I've actually got thousands. I've got hundreds of questions. I'm sorry, but the ones that I wanted to really ask, and they're a bit rhetorical, really, I guess. But the one is this transition between national policy and local action, and it really follows on from our last question. Really, it's one thing to have patients involved, but it's another thing for them to be part of the solution for action. And it's how we can use that power that patients have. We often talk about empowerment. I'm trying to sort of produce a movement that takes the M out of empowerment, because empowerment suggests a bit of hierarchical, will give you some power if you want it. Whereas if we give them the power to shape and change, then they need to be actually part of the process. And I'm just wondering how, because I think there's a fantastic opportunity for PSIRF within this, and also to show a light to other countries in the world as well. So, I mean, there's two elements here. One is how are we translating national policy into a local action that patients really are shaping local systems. And then the second element of that would be how, therefore, are we then starting to identify this as a real method? Because you've talked about safety management systems in other countries where this is actually part of a lot of those systems. So I'm just wondering how we can elevate our own conversation outside of the country. But first and foremost, what are we starting to see from patients in terms of changing local cultures with regard to patient safety?
Yeah, I mean, I guess so through reading some of the plans that I've had the opportunity to go through, there is some engagement there in how patients are shaping the governance structures and being part of that. Wasn't in all of them. I think there's potentially, you know, with having patient safety partners and PSIRF and so on at the same time, some things came before others, but there's definitely a role there. And for us to demonstrate, you know, examples of where that's working well across the system, and I guess demonstrating examples of patient contributions to the work that we do. So that thinking nationally about how we work with our patient safety partners, and that presentation we did together for IHI BMJ, it was really clear how helpful it was to have that patient perspective reviewing the plans alongside the way I reviewed them as well, and how we picked up on different things and trying to pick out those examples and sharing them so that how patients participate in this work isn't just a tick box activity, and actually they're contributing meaningful work and they get feedback on that. So I think that's definitely something we can build on. And there's also, I guess, the other end of that, if it's the other end or not, but in how you know, those who are affected by safety events and how they're involved in the process of learning and in the kind of the learning response process, but then also where possible involved in the development of those actions and so on afterwards. And I think we've touched on that in our engagement guidance, but there's potential room there as well. And I guess, but then thinking about PSIRF more broadly and how this principles-based approach can apply across different healthcare systems, it's also interesting to see how it could apply across different safety critical industries as well, because even in the likes of aviation and oil and so on, that are usually kind of placed on very high pedestals for their approach to safety, still require every event that meets a certain criteria to be investigated. So I think there's learning potentially for other safety critical industries, and I guess as well around the approach of how we investigate, looking more proactively, looking at the context in which work is being done, and I guess you know, using some of that work that was written about in 2004 around not looking in the rear view mirror and taking a find and fix approach, but looking more so to the future and the context of work every day. All of these elements of complexity aren't necessarily reflected in safety management systems that can be quite linear and barrier management based. So I think there's lots of learning both ways there. But also, yes, absolutely across healthcare systems. So we've had some connections. I mean, I've previously worked in Canada, so I have some connections there and had some calls with Healthcare Excellence Canada. But yeah, there's definitely opportunities, I think, to share it more broadly with the healthcare systems.
Great, thank you, thanks. Have I got the next one, Rebecca? Can I just ask?
You can have one small one, Mike, and then it's on.
Okay,
Cheers.
this is a real little one. About how are you going to be? How are we as a system going to be using PSIRF to identify future research priorities, hopefully funded graciously by NIHR?
I mean, that's kind of another real great opportunity with these patient safety incident response plans. So there's the opportunities locally within ICSs, for example, but we nationally have those opportunities to recommend research ideas through the Department of Health and NIHR, which is where the safety management system work started. So it was a recommendation to the research and development team at Department of Health. So there is really an opportunity there to look at the priorities coming out of the plans across the system and using that to define the research that we make suggestions for through the Department of Health into NIHR. So there's absolutely opportunities there for that data.
Thanks, Tracey, and thanks, Mike, for your questions. Ruth Baxter.
Hi, Tracey. Thanks for a brilliant presentation. I was just wondering, and I'm really sorry if this is out of date, I've just come back from maternity leave this week. So if I'm completely out of the filter, then just let me know. But I'm just reflecting on the very different context that maternity services are currently in, both, I suppose, culturally and also in terms of them actually having to report all of the safety incidents that occur to an external organisation. Being a regulator, and I was just wondering if you had any kind of reflections really on how it's currently being implemented within maternity services, and any kind of thoughts on how people are doing that well.
Yeah. So I think maternity is always it's got such a spotlight on it. So this when you have this idea of autonomy within an organization to develop their patient safety incident response plans, with such a spotlight on a sector, it's been a little bit trickier to embed some of the principles in the maternity sector as it has been in other sectors. But through reading through those patient safety incident response plans, I think there are kind of some real clear examples of where organizations are including maternity within their broader patient safety incident response plans, because there are those opportunities to learn more broadly across certain themes. For example, deterioration is one theme that runs through maternity, but in other parts of an organization. And so in some places there's a lot more collaboration between a broader patient safety team and a local maternity governance team in how they do some investigations related to some of the broader themes that organizations want to work with. But I think there will be a variety. I think in some cases we are still seeing kind of patient safety incident response plans for maternity. And I think that's fine. And we saw some of that in our early adopter program as well. But ultimately, we want to make sure that that is embedded within a wider organization's approach. And so there's still ongoing work, and we are doing some work to produce some case studies specifically to share how different organizations have adopted PSIRF principles within maternity, and how certain events that may have been an SI in the past are being discussed and responded to and learned from under PSIRF, to share those examples more widely. So that's some work that's ongoing at the moment.
Thank you.
Welcome back.
Thank you so much. I'm going to stop now, but Tracey, if you've got a couple of minutes, Claire Marsh does have another question that she'd like to ask you, but I just want to give everybody an opportunity to go off to other calls, and just to thank you publicly for such an excellent talk, and for just taking the time out to come and do this today, which obviously you don't have to do, so it's very much appreciated. Thanks for that. And anybody that needs to leave, please do. We'll just have one more question though, if that's okay. So Claire, I think you were wanting to ask more about some of the. So when we saw the slides from Tracey, they were kind of very much focused on patient safety outcomes, weren't they? Things like falls and self-harm and diagnostic errors and things like that. And I think you wanted to ask about some of those more system level factors that might span different settings. So I'll hand over to you.
Yeah, thanks, Rebecca, and thanks, Tracey. Yeah, I was just thinking that whether this does offer the opportunity to raise the issues, the cross-cutting issue of short staffing and workforce, which will be, the factors affecting a lot of the themes that are coming out in patient safety plans. So do you think there is scope for that to get picked up via this process so that it becomes something that can be reflected and responded to, especially if ICSs are looking at all the issues coming out through the plans?
Yeah, I mean, I think absolutely. I think at the moment, the way the plan template is designed, it's very much a kind of incident response template. So that kind of almost necessitates it to be an outcome in a way. So this has happened, how are we going to respond to it? But I think as it comes back to that kind of opportunity to be more proactive. So as you're kind of doing that review of your data, your past learning responses, your improvement work, and using that to inform your plan, there may be issues that you see, for example, staffing and so on, that are coming out across that. And so rather than having that as a response priority, you may have that as an improvement priority, for example, and you can start to work more towards that as almost kind of, I don't know if we call it a learning response, but there are certain methods you could use to try and tackle that as an improvement priority. But I think that is definitely something that will come, and I think we will have to work to adapt the planning template to accommodate that. I think there are opportunities to be more proactive, but at the moment it's still very much kind of response based, but that's where I could see it sitting.
Yeah, thanks for that. That's a helpful way of thinking about it.
Just a final question from Justin, but I think you've actually answered much of that question in your response to previous questions. It's just about the integration of PSIRF implementation with other kind of strategies that are being developed, such as the LFPSE and the patient safety partners. So thank you for that question. And we've had such positive feedback in the chat, just congratulating you, thanking you, Tracey, for the talk. So I think we'll close there now. Thanks very much.
Thanks, everyone.